right, so we'll get started. Good afternoon. Thank you all for joining us. My name is Julie Cronin. I'm the president of the American Nurses Association, Massachusetts. I'm also a very proud registered nurse, and I'm a nurse director in oncology at Mass General Hospital. Welcome to the first in our new webinar series, Commonwealth Conversations. We are so honored and grateful to have our Massachusetts Governor, Charlie Baker, joining us in our conversation today as our inaugural speaker. Governor Baker, we realize how incredibly busy your schedule must be, and we are truly, truly grateful to you for taking some time out of it to be with us today. Just to set the stage for our viewers at home, our goal today really is to just have a conversation about some of the issues that are relevant to nurses in our state, and also just to talk about some of the challenges that we're facing in nursing and healthcare in the time of COVID and beyond. And with us today, we have 3 ANA Mass members who are also direct care staff nurses. And ANA Massachusetts is a constituent member of the American Nurses Association, and we're the largest voluntary professional nursing organization in the state. So we represent every nurse from the bedside to the boardroom. So direct care nurses, educators, innovators, advanced practice nurses, leadership, and beyond. And as ANA Mass members, nurses have the unique opportunity to do things like advocate for policy and legislation that affects them in their daily practice, and to have Zooms with their governor, and to attend educational opportunities and get CEUs, and also to network with nurses, not just in the Commonwealth, but across the country.
Does anybody get CEUs for this?
Sadly, no.
Just wanted to know how, what level of esteem I was going to be held at with respect to this, and you've answered that for me, so thank you.
Next time, we'll plan ahead for that. So as I mentioned, we have 3 wonderful ANA Mass members here with us today who are direct care staff nurses, and they have compiled a list of questions that they've either devised or have been submitted to us through our ANA Mass members. So prior to them asking their questions, I'll just have them give a brief introduction and bio. But first, I'd like to kick it over to you, Governor Baker, to see if there's anything you'd like to say to get us started prior to jumping into the questions.
Well, first of all, Julie, to you and the folks who are on the call, I want to thank you for this opportunity to chat a bit. I find it highly ironic that you would have referred to my day and my life as busy, since you are speaking on behalf of a profession whose daily life has been, well, we'll just call it busy for the better part of the past. Well, it's always busy, but I would imagine the last 5 or 6 months have been particularly incredible. And I would just say that I'd say all the time that one of the reasons we managed our way through this really awful and dreadful process of the sort of late winter and spring and into the summer was the quality of the healthcare community that exists here in the Commonwealth. And I was on phone calls every day with folks in the healthcare community and a whole variety of other communities as well. But the most interesting thing to me was how grounded and focused the folks in the healthcare world were to the task at hand and the work to be done, despite it all. And I am quite aware of what the it all part was all about. I mean, I never thought when I ran for governor that one of my primary jobs would become hunting down PPE from all over the world, or that I would end up spending significant parts of my day in the months of March and April, calling everybody I knew who might know somebody somewhere who had access to either gear or a plane, and then trying to figure out how to actually get that gear past the gates at the airport so that it could actually go where it was, or through the port so that it could actually go where it was supposed to go. And during this whole period of time, I know quite well that the awesome responsibility and task that was placed on the nursing community, the physician community, the tech community, the food service folks, sort of all of those who were dealing with this stuff on the front lines every single day was extraordinary. And I was constantly amazed by the work that was done and by the commentary that we got. You know, we didn't shut down our constituent service operations. I mean, people are still, throughout the course of all of this, reaching out to us about things they're either glad about or really mad about. And I can't tell you how much incoming we got about, which was really just gratitude for the healthcare community and the nursing and the clinical community here in Massachusetts. Just coming from people who were scared out of their minds, and more often than not, were able to send a note in here or send something to the online address because somebody somewhere along the line, or some group of somebody's, worked what I would describe as a miracle on their behalf. And I, you know, sort of a cliche to say that Massachusetts has a really wonderful and special healthcare community until it absolutely positively has to have one. And then it's not a cliche anymore. It's just something we can all be incredibly grateful for. So I want to just say thanks on behalf of the people in Massachusetts for not just what you do every day, but especially what you did over the course of the past 6 or 7 months.
Thank you so much for acknowledging that. That was really heartfelt, and couldn't agree more. Everyone was grounded and focused and dedicated, and it was just awe-inspiring to see what we saw and to do what we did throughout the pandemic. So we are committed to doing whatever we need to do going forward. And your note about the PPE was a good segue into our first question. So Laura, I think you're up, and I'm gonna turn it over to you.
Thank you, Julie. My name is Laura Duff, and I am an active member of our Health Policy Committee. I'm a registered nurse and a clinical nurse too at Beth Israel Deaconess Medical Center, and I work on a cardiac intermediate care unit. The American Nurses Association Massachusetts first wishes to express its sincere appreciation for the efforts and lengths that you, Secretary Sutters, Commissioner Burrell, and others undertook to secure PPE during the height of the first wave of the coronavirus pandemic. PPE remains the top concern of nurses across the Commonwealth and the nation, as revealed from 2 national surveys conducted by ANA. Nurses have continued to identify insufficient supplies, both quantity and quality, of PPE, and are being asked to reuse PPE when reuse is contrary to manufacturers' guidelines. The ANA recognizes this is a crisis capacity strategy, but does not support the use of decontamination methods as a standard practice. What steps is the administration currently taking to ensure that all healthcare providers have adequate PPE at the pre-COVID standards of care without decontamination or reuse? How is the Commonwealth ensuring that there is equitable distribution to non-acute care providers, such as long-term care, nursing homes, and school nurses?
So I'm going to start, Laura, and I'm not just bragging the puck here, but since you work at Beth Israel Deaconess, I need to tell you a story about the nurses in the nursery there when our first child, who's now 29, was born. He was a complicated delivery, and he spent a little bit of time in the NICU, but mostly he went to the nursery. And after a couple days, my wife and I were told that we would be able to take our firstborn home, which was unfortunate because we really wanted him to just stay there until he was 18. And but the folks in the nursery gave us their phone number and said that if we had any questions, we could call. So after we'd been home for 5 or 6 hours, I picked him up out of his crib, and he was really hot, and I was terrified. So I took the card out and I called the number, and a nurse in the nursery answered the phone, and I said, "This is Charlie Baker. You guys gave me your phone number. I just left with my son, and they knew who I was, and they said, "What's the problem?" And I said, "Well, he's like burning up. I really think I need to bring him back in." And she said, "Well, how many blankets is he wrapped in?" And I started peeling, and I said, "I don't know, 4 or 5 maybe." And she said, I'll tell you what, why don't you just take the blankets off, lie him down, and see how he is in 20 or 30 minutes. And sure enough, 20 or 30 minutes later, he was fine. And the cost of that whole experience to the healthcare system, nothing. And it was a horribly embarrassing moment for me, but a really great example of what somebody who really understands the nature of their work can bring to the table. With respect to PPE, that is not exactly something that, as I said in my previous remarks, I got into this job expecting to work on. And over the course of the past 5 or 6 months, we've probably acquired and distributed either through the federal programs, but mostly on our own, about 35 million pieces of PPE. Mostly gowns and masks, but tons of gloves and coveralls and all sorts of other stuff as well. And a big part of what we've been distributing has been to the folks who typically don't have access through traditional channels. So it's been going to the folks who serve people with developmental disabilities in 24/7 residential programs, or the folks who serve folks with mental illness in similar kinds of residential programs, or nursing homes, or other kinds of congregate care facilities, or some of the smaller hospitals or the LTACs that don't have access to the resources that some of the bigger systems have here in Massachusetts. And one of the things we tried to do here was to learn some lessons from that experience. And so we created a program to actually invest in companies in Massachusetts that were willing to start making gear. And we now have companies from Fall River to Lawrence who are making gowns and coveralls and masks and gloves. And we helped them all get through the FDA process to get their stuff approved. And we are their biggest purchaser. We're literally buying millions of pieces of equipment from these folks, and plan to continue to buy millions of pieces of equipment from these folks as we head into the fall, and load it all up in our stockpile over at MEMA, and we'll continue to inventory it and distribute it based on demand and the calls that we get from people about what they're looking for. We also spent a lot of time trying to find domestically produced N95 masks, which I think, as everybody knows, was a giant, just unbelievable mess all the way through the months of March, April, and May, and June. And the good news here is through a series of conversations that took place directly with some of these manufacturers, we weren't working through distributors, we managed to get to the point where we had a pretty solid agreement in place to buy on a scheduled basis over the next 5 or 6 months, very significant amounts of N95 masks. And one of the things we did as part of our check process on this was gave some of the masks to the M&A and asked them if these were masks that they would consider to be appropriate for use by their members. And they said yes. And if they hadn't said yes, we wouldn't have bought them. But I do believe we will be able to provide a significant amount of support with respect to PPE to what you referred to as the sort of non-acute, non-traditional system-based healthcare providers as we go forward. And I get asked all the time, you know, when do you have enough PPE? And the answer is never. I'm just going to keep buying it until we get to the point where someone tells me we don't need it anymore. But I don't expect that to be anytime soon. We're going to continue to have shipments coming in on this stuff. We're going to continue to buy from some of the local folks that we got into this business. We're doing some other stuff that may actually lead to some ability to actually produce and procure significant amounts of N95 masks right here in Massachusetts. Hopefully we'll have more to say on that at some point down the road if it works out. But we are very much committed to this idea that global supply chains during periods of scarcity don't work. And because nation states get in the way and start to basically decide that you can't access, you basically get shut out. And this wasn't just true with respect to masks. We ran into this with gowns, we ran into it with gloves. And so one of the things we're trying to do is to make sure that we are sourcing as much of this stuff as we possibly can from companies that are either in the general vicinity of the Northeast US, Massachusetts, or somewhere in the US, because I don't ever want to get trapped in a scenario where the issue comes down to a nation state basically saying no. I mean, we're buying big quantities, and I think we'll be in pretty good shape.
Thank you so much. PPE is such an important topic, especially as we're heading into the fall months. So we really appreciate your thoughtful response. And I'm also very glad to hear that you had a positive experience with my hospital. So it's wonderful.
3 times.
The next question we have comes from Silda.
Hi, Governor Baker. My name is Silda Mello, and I serve as a new graduate director on the ANA Mass Board of Directors, a position earmarked for nurses with less than 5 years of experience. I am a complex care nurse manager at Boston Medical Center. Over the past 10 years, ANA Mass has supported multiple bills to give nurse practitioners full practice authority, which you included in your healthcare reform legislation. We recognize your foresight in including this language in your temporary executive order issued during the pandemic. The removal of practice restrictions to advanced practice providers has been beneficial to the citizens of the Commonwealth during the pandemic. However, this is still only a temporary authority. There is currently a healthcare reform bill with nurse practitioner language pending in a House Senate Conference Committee. What is the administration doing to move this along?
As Mary Lou Sutters would say, well, we're not eating bonbons, okay? Look, I go way back on this issue of nurses being able to practice to the top of their license. The last time we actually got some fairly significant changes with respect to the roles and authority that nurses have was in the 1990s, when I was actually working for Governor Paul Cellucci, who was, there'll probably never be a bigger advocate for nursing generally than the late Paul Cellucci. And we managed to get a series of initiatives passed that changed a number of the dynamics associated with the way licensure works here in Massachusetts for nursing. We are talking to all the people we think we need to talk to on a regular basis. And one of the points we're making to people is there's no going back on some of this. You can't put in place a program that was done to solve a very particular problem that is with us still today, and in which the nursing community has performed by all accounts at an extraordinary level in responding to, and then decide to turn the clock back and change the rules at some point down the road. The emergency order is going to stay in effect until we believe the COVID issue is no longer a threat to the Commonwealth. And I don't know when that will be, and I don't pretend to know. But telehealth is another issue. It was invented here in Massachusetts, and yet somehow it wasn't statutorily permitted in any kind of serious way until we issued an order associated with the pandemic. And I don't think you can find anybody on the patient side or the clinical side who doesn't think that has ended up becoming an enormously valuable and important tool to take care of people, separate and apart from the issues associated with minimizing infection when people are dealing with each other, either on a phone or on a FaceTime or whatever it might be. And I view this the same way. And the message we've been delivering to our colleagues in the legislature is we're the only state in the country that isn't here with respect to the kind of authority we're looking to provide to nurses and to nurse practitioners. And I am very optimistic that we'll be able to get this done before the end of the legislative session. But I'll tell you this, we'll be really aggressive about making sure that we don't end up making our situation in Massachusetts with respect to nurses' ability to serve people that they are perfectly qualified and capable of serving and have done so throughout the course of this pandemic. And I think it's going to be, one thing you guys could do for me on this one is to make sure how important this is to you, to reach out to your legislators. You know, Julie talked about the fact you have a really big membership. You folks should be reaching out to your legislators and making the case to them at the same time about how important this is for you. And the other thing I would suggest, and now I'm getting a little probably outside the traditional bounds on some of this, I gotta believe you all have patients who you've taken care of over the course of this who would love to call their legislator or drop them an email and say how important it is that nurses have the authority that they're trained to have, and that they currently have in many cases under the existing orders, and that we, you know, sort of right or wrong, that's been in place in Massachusetts for a long time. So I'll do all I can. I think you folks should be reaching out to your legislators, and I also think it would be terrific if some of your patients did the same. And the other thing I would say, since Julie talked about the fact that you're from the boardroom, from the bedside to the boardroom, get some of those board members who sit in those board meetings with nurses who are on those boards to pick up the phone and make some phone calls of their own. I mean, we should full court press this. There's no reason why we shouldn't join the rest of the United States of America and just get this done.
Thank you, Governor. We've provided testimony multiple times and members have reached out. We'll continue to encourage our patients to also reach out. This legislation will ensure patients receive access to high quality care with demonstrated excellent outcomes. Our next question comes from Denise.
Hello, Governor.
Hey, Denise.
Hi, my name is Denise Moringue. I am a former new graduate director on the ANA Board of Directors here in Mass, and I'm currently serving on the national level at ANA on the Nurse Practice Advisory Council. I am also a direct care staff nurse at the emergency room in Holy Family Haverhill and at the COVID clinic for NSPG Danvers. Our next question talks about our elderly. So the long-term care was in a state of distress before COVID-19. The effects of the virus on our elderly population has been horrific. What are our next steps to support the nurses and nursing assistants who practice in long-term care, and how do we protect our elders? And secondly, how can nurses at the bedside in these settings be empowered as the decision makers and have access to the resources needed to protect their residents and themselves?
So there's a bunch of questions in there. I'm going to tackle the ones that I think I have the answers to, and a couple of the others I might have to get back to you on. COVID, the brutality of COVID is so much more present in long-term care, and I have personal experience with this one. My dad lives in a continuing care community. He's 92 years old, and I went. I used to have dinner with him literally every weekend for the better part of the past 3 or 4 years after my mom died, and I went 100 days without seeing him. And I talked to him a couple times, and really had no idea what the hell was actually going on. And I know no one else did either who had somebody in that situation. And I had friends who lost moms and dads during that period of time under the cover of COVID for all intents and purposes, and had to go through very limited ceremonies to actually have a chance to say thank you and God bless to their parents. The whole issue around visitation has been brutal, and it's one of those ones where everybody intellectually understands why the rules are the way they are, because it has a lot to do with contagion and infection control. But it's even if I get it here, it doesn't mean it doesn't hurt here. And I think for a lot of people, that whole thing has just been incredibly hard. And that's not just here in Massachusetts. It's true everywhere in the US and frankly, everywhere in the world. COVID was made to attack long-term care. And I think one of the things we've tried to do, working with our colleagues in the long-term care community over the course of the past 5 or 6 months, is to both invest in staff and in institutions. And all in, I think we put almost $300 million into our long-term care community in Massachusetts since April-ish. And the first round was about $140 million, which was mostly about support for staff. And the second 140 million was about staff and infectious disease control and a whole bunch of other initiatives around enhancing our support for sort of what I would describe as surveillance and ongoing testing protocols that we continue to do to this point in time around staff and contractors and visitors. And I think we've made a lot of progress there, but I think we have a lot more we need to do. And Mary Lou Sutters, the Secretary of Health and Human Services, and who's now running the command center, and Dan Tsai, who runs the Mass Health Program and is interim secretary, are spending a significant amount of time with the long-term care industry on sort of what the next act is here with respect to our ability to continue to serve and support folks who work in those spaces. And I fully expect that over the next, 3, 4, 5 months, we're going to continue to be both investing in dollar terms, but also investing in terms of some of the stuff we talked about when Laura asked me the question about PPE and gear and in surveillance and in testing and all the rest. And honestly, I really hope one of the things that happens here as some of these testing protocols get a little more accurate and a little less complicated is that we can start to use those to make it possible for people to go visit their family members. That's not exactly in the line of what you asked, Denise, but honestly, I think it has to be really hard to be a caregiver in a community where so many people do not have access to their family, and vice versa. All right, I've tried to be a good sport about the fact that I really can't see my dad very much at all anymore. But I live in this world and I sort of accept it. I'm sure for a lot of other people, it's not like that. And I have to believe that some of that ends up being reflected in the way people relate to the people who are taking care of their family or to the people who are taking care of them. And so one of the things we're trying to figure out is some way to maintain the safety associated with visitation, but at the same time to make it possible for a little more of that to happen, because I think it would take some of the edge off. I actually think long-term care probably right now, even though the COVID thing for the most part, because of a ton of hard work and resources from a lot of different people, is in a much better place than it was 5 or 6 months ago. But I have to believe there's still a tension associated with the inability to bring the outside in and to have the inside go out. It's got to land in some respects on staff. And that's something actually that I think we should talk about, because I got to believe that's really hard on the professionals who are trying to do their job, but are dealing with a really difficult dynamic around the bubble that's associated with long-term care. Am I right about that or not?
You're right on.
Okay.
Yeah, no, it's been devastating, I think, to care for patients and see as they are suffering and they can't have their loved ones with them. I think we've all experienced it in this time. So long-term care, but also acute in the emergency department and everywhere in between. Like you said, you get it, why it has to happen, but the heart of it all, it doesn't feel right.
I just have to believe that, when someone gets told, that they can't come see their family member because it's raining and it has to be done outside, both the family member who's not going to have a visitor, who's probably been really waiting and hoping and anticipating this, and the person who can't come are both angry. And that anger, I have to believe in some cases gets directed at the wrong place, which is at the person who's just trying to make sure they keep everybody safe. So I would like to talk some about that too at some point, if you guys are up for it.
Absolutely. Absolutely. So I just want to do a time check. We do have we have a few more questions, but definitely one more we'd love to get to. It's related to health disparities and systemic racism. So if you have time, we'd love to ask you that one. So Laura.
Thank you, Julie. So I have the privilege of asking this next and very important question from our membership. COVID-19 exposed the reality that systemic racism has led to long-standing inequities in healthcare and striking disparities linked to COVID-19. Black people are dying from COVID-19 at a rate 2.4 times higher than white people. Nurses have a responsibility to use our voices to call for change. ANA Mass is addressing racism in the profession and healthcare disparities on November 9th by hosting a virtual conference led by ANA President Dr. Ernest Grant. What steps is the Commonwealth taking to address population health disparities, including the prevention and treatment of COVID-19? What should the Commonwealth be doing to address the systemic problems that contribute to racism, such as healthcare coverage and access and social determinants of health?
So let me start by saying that while we have a lot of work to do in Massachusetts on these issues, I do think we sometimes don't give ourselves credit for the work that has been done. And again, I've been around the healthcare space and state government now for 30 years, and I was around when we enacted what I would call one of the first steps toward getting us to universal healthcare coverage here in Massachusetts. And I was working in the healthcare world and pretty involved in advocating for the legislation that eventually led to the first round of this, which was the late 1990s and the early 2000s. And then I was involved again when I was working in the healthcare world on advocating for and delivering in this job on a 5-year waiver that gave us a lot more flexibility about how to distribute resources under the Affordable Care Act. And we did a ton of work when we took office to clean up the way the healthcare connector was working, which was a mess, and served primarily self-employed and low-income workers, many of whom were people of color. And I think we should start with a recognition that in Massachusetts, for the most part, everybody has coverage, all right? That makes us really different than what you're gonna find in 49 other states. And does not mean we don't have tons of stuff to do, but it does mean that we have taken on one of the issues you mentioned specifically in your comments, Laura, which is the whole question around access to coverage. You have a lot of states where, you get 12, 10, 14% of the population that's not covered. I've thought a lot about what that means in the context of COVID. I mean, for all our issues and our problems, my God, at least people here in Massachusetts, for the most part, with very few exceptions, have access to insurance coverage, and those that don't know where they can go to get their health care. So I'll just start there. That's kind of the good news. The stuff that needs work is a pretty long list. And it starts with things like, what are we able to do when you get into a period like this around things about like food security, okay? We spent a ton of time on food pretty early on in this pandemic because we were really worried about whether or not people were going to have enough to eat, and especially people who worked in certain industries that just got absolutely hammered straight out of the gate by the rules and by COVID generally. And then secondly, if you're here and you were working and you weren't documented, you don't have access to any of the public programs that are currently part of the mix. And so figuring the food thing out became a really big deal. And we've put somewhere between $50 and $100 million into food initiatives since we took office, or since COVID began. And a lot of those have ended up serving, especially in a big way, residents in communities that have significant issues around density, significant around issues around documentation, and significant issues around some of the issues associated with racism and social justice that you discussed previously. We also built our Stop the Spread program around trying to spend a lot of our resources around access to testing in communities that have been underserved. And if you look at, we now have, I think we have 30 communities in our Stop the Spread program. The vast majority of them are communities that have not had access to the kinds of testing that's available in other parts of the Commonwealth, and that's why we put it there. And a lot of the stuff we put in place around isolation programming and isolation programming, meaning programming that makes it possible for somebody, if they're living with 3 generations and one person gets sick and they only have 4 bedrooms or 3 bedrooms or 2 bedrooms, and they don't know how they're going to be able to create some distance for the person who's actually got COVID from the people who don't. We worked pretty hard to build a pretty significant and robust system to provide them with access to shelter and to housing that would be available to them so that they could in fact separate themselves from their other family members during their quarantine. Our contact tracing program speaks 26 languages. That wasn't an accident. We wanted to make sure that people would be reaching out to people in languages that they would recognize and understand. We also have a pretty robust collection of experts serving on our Health Equity Advisory Board, which was put together as a function of the COVID stuff because we realized that we didn't have enough voices around the table who could help us make good decisions about how to think not just about COVID, but about what happens after COVID. And I do believe that group is going to end up providing us with a roadmap that will make it possible for us to deal with a bunch of the issues in the healthcare space that we need to deal with respect to access. And the final thing I'll say is I think we were the first state in the country to mandate, and again, this is another one I did with an order. When the order goes away, I lose it. So we have legislation pending on this too, which I'd love to have your help on, to mandate that the labs and the testers, the providers and the labs have to report to us on gender, ethnicity, race, and a whole series of other really important elements with respect to their testing data so that we know who's being tested, where they're from, what their gender is, what their race is, and what their ethnicity is. And again, we have that out there on an order and people are pretty much following the order, but we don't have it in statute yet. And we filed legislation to put it in statute and would love to have your help on getting that done, because I do think to be intentional about this, you have to ask for certain kinds of data and mandate certain kinds of data so you can actually create the framework to have the conversation about what you're going to do about what you discover when you start collecting that information.
Thank you so much for your very thoughtful response. This is such an important topic and we really appreciate you sharing the strategies going forward. Thank you so much.
So we've talked about many, many initiatives today, and we appreciate your candor, Governor Baker, in speaking with us. And ANA Mass, and I know nurses in the Commonwealth are definitely committed to doing whatever we can to help, especially going forward. I think at this point we could wrap up. I just have one other question. And so—
She just kind of snuck that in there, didn't she?
Yeah. It'll be brief. So of course,
I do want to follow up on this long-term care thing that Denise brought up, okay? I think we should talk about that. Yes. Somehow, through some channel.
Happy to. So we don't want to look back because I think you've given us some great things to think about in terms of the future and how we're prepared and how you're advocating for us as citizens of the Commonwealth. And we really appreciate all you've done to protect us and to move things forward. But we did want to know, what do you feel, if anything, the Commonwealth has learned from COVID-19? And also, what, if anything, do you feel you or the administration would have done differently?
Well, if I'd known that 3 million N95 masks that we ordered were going to disappear in the Port of New York, I probably would have started to chase PPE a little earlier. I certainly think the PPE issue just put everybody in a terrible place. And part of the reason why when people ask me when I'm going to stop buying it, I say maybe never, because I don't ever want to be in that situation again. I couldn't believe we were asking healthcare providers. We weren't asking. We were making healthcare providers in the midst of a terrible pandemic work without some of the gear that I think everybody believed was, you know, sort of fundamental to their ability to do their jobs. And so I think I mentioned earlier in my remarks this whole issue of the global supply chain, which works fine until it doesn't. We need to find ways to access stuff a lot closer to home, and we've been spending a bunch of time on making sure that we're able to do that. I think the issue that was raised in Laura's last question around what are we going to do to make sure we do a better job of creating a more equitable healthcare delivery system is a really important one. And, you know, COVID's with us for a while, but some of the lessons and the issues that have been raised are not going to go away when COVID goes away. And I think that health equity task force that we've got can help us figure out how to make sure we do the things we need to do there. I do think the whole issue around infection control in long-term care, there's kind of a cookbook on that, but it wasn't really, it wasn't something that was part of every conversation that took place between the Commonwealth and the industry, and it probably should have been. And I think it probably will be going forward. But along with that is going to have to come support from us to make sure people have the ability to do what they need to do surveillance. And that's why we continue to support these testing programs that we're continuing to implement as we go forward. I think that was a huge lesson. I think the final one is I would hope that that as a country, one of the things we take away from this is an understanding and appreciation for the fact that traditional public health, which often takes a back seat to a lot of other parts of healthcare that are sort of flashier, needs to be a mainstay of the healthcare system we have, not just here in the Commonwealth, but around the country. And we have varying degrees of sort of support for and sophistication across our local boards of health too. But I'm not just talking about that. I'm talking about sort of just public health generally. You know, the sorts of things that have to do with population-based healthcare and an understanding and appreciation about some of the social determinants, which Laura also mentioned. We don't do anywhere near enough research in that space, and we need to do a lot more. And I think all of those things are lessons certainly that I learned as we got into this, and as we start to sort of work our way through what I think of as the middle innings of this. The final thing I'd say is, and I'm going to go back to where I started. I said at the end of my opening remarks that people take the healthcare community in Massachusetts a little bit for granted. Everybody knows how strong and well-trained and committed it is, and you are. But I think we sometimes, because you're our neighbors and our friends and the people we used to go out to dinner with back when we went out to dinner, we don't really get sometimes just what we have here until we end up in something like this. And I think it would stink if we don't take the gratitude and appreciation we got out of that, and do some things with regard to telehealth and nurse practitioners and nurse scope assignments and Health Policy Commission. I mean, there's a whole bunch of places where we could make big statements about healthcare, about public health, about equity, about race, and about nursing. And we shouldn't miss the opportunity whenever COVID goes away to not make sure we follow through and execute on all of those things.
Thank you so much. We are definitely committed. We're with you to work on long-term care, PPE, mental health, health equity task force, you name it, we're there. ANA Mass has filed legislation to have a registered nurse for a permanent seat on the Health Policy Commission. So
is there a registered nurse on there now?
there's not, but we were hoping you could help us with that.
No, there actually is a registered nurse on it now.
So Barbara Blakey filled
We just put one on it. There was a seat for it. We just put one on it.
So Barbara filled the innovation seat.
It's even better when you do it when you don't have to, right? I mean, in some respects, we wanted the voice there whether we had the, requirement or not.
Okay, we'll have another one. We'll have two.
She's not going to give me anything for that. Okay, it's fine.
Thank you for that. We appreciate it very much.
Again, just want to say thank you to you and to all the folks who are part of your community. You really make me proud to be able to say I'm from Massachusetts. So thank you.
Thank you. We are so proud to have you as our governor. We really appreciate all you're doing for us and really appreciate your time in talking with us today. Hope we can do it again. And so I think we'll end there. We really appreciate your time, and hopefully we'll have another Commonwealth conversation soon, and we'll follow up with you after this if there's anything that we would love to be helpful.
Sounds good.
All right. Thank you so much.
Thanks very much. You guys take care. Okay.